Good morning, everybody. Thanks a lot for connecting for another virtual seminar from the Tisch Cancer Institute seminar series. So today we are going to have two talks. The first one by Dr. Thomas Marron on his work on cancer immunotherapies and also a little bit of COVID-19. And then at one, Dr. Ramon Parsons will be talking about how we are going to go back to the lab. So I will start by introducing Dr. Marron. He's an assistant professor at the Department of Medicine and Division of Hematology and Medical Oncology. He's also the assistant director of early phase and immunotherapy trials. He's an MD PhD, and most of his training was done here at Mount Sinai. He got his PhD working in Charlotte Cunningham's laboratory. And then after the residency in internal medicine, he did a postdoc in the laboratories of Nina Barwash and Joshua Brody. The list of awards that Dr. Marron has is really, really long, so I will just mention a couple. He has received awards from SITC, which is the Society for Immunotherapy of Cancer, and also from the Cancer Research Institute. He's a very prolific researcher and also clinician, and it's a real pleasure to have him present here today. So before he starts, I will just remind you to mute yourself. You can do that by clicking in the lower left part of your screen. And also, please submit your questions through the chat function. So Thomas, go ahead.
There. All right. So thanks for having me. I'm going to talk a little bit about some of the trials that we have ongoing right now and some of the research that's led to that. And then I'm going to kind of piggyback on some interesting data about COVID-19 and an additional trial that we're opening in that space as well, since I think we're all kind of having turned into COVID doctors at the same time as being oncologists and immunologists. Here's my disclosures. Number one is I'm a phase 1 doctor, and so everything I do is basically off-label and primarily non-FDA approved drugs, and I'm going to be talking about a bunch of those today. So before I show you data, I want to just thank the folks who made a lot of the data possible that I'll show you, which is kind of the setup for many of the clinical trials we're doing, and particularly Andrew, Yonit, and Maria, who are in Miriam's lab, as well as work they've done with Effie, is really the cornerstone of some of the nice transcriptomic data which supports the trials that we're doing. And I'm going to talk to you also about a clinical trial in COVID that I've been developing with Scott. That's also, I think, very exciting, potentially, particularly for our very sick patients in the hospital, for which we have very few therapeutic options. But there's, probably 150 additional people that I do have to thank for all the collaborations that are involved here. So as everyone on this call knows, immunotherapy has really revolutionized the way in which we treat many cancers, particularly lung cancer. I'm a thoracic medical oncologist, particularly on Friday mornings when I treat people off-label or off-trial. And our standard therapy now for patients who have metastatic lung cancer is a combination of chemotherapy and immune therapy. And the addition of immune therapy to chemotherapy more than doubled the median overall survival we're seeing in these patients. So going from around 10.7 months to 22 months, it's pretty impressive. You don't really see Kaplan-Meier curves that separate like this in cancer very often. So there's a lot to celebrate. These huge changes are really benefiting our patients with relatively minimal increased toxicity. But the main problem is that the vast majority of our patients across histologies are still dying of their cancer. So we don't really understand exactly what the optimal treatment regimens will be for patients, which patients are going to benefit from which treatment regimens, and also what we do after patients progress on what is now the standard first-line therapy, which is the chemoimmunotherapy. And the question of what to do next is a very complex one because, as many of you know, there are literally thousands of different IO agents in development right now. So the Cancer Research Institute here in New York regularly keeps track of all the different agents that are in different IO trials, either preclinical or clinical. And the last update, which was from last fall, showed that there were 3,876 IO therapies that were in the development pipeline. And that was up 91% over the course of 2 years. And I think now we're well over 4,000, being nearly a year out from this tabulation. And one of the main issues is that, we have all these exciting new agents that have been developed based on our understanding of basic immunology and of cancer immunology. But most of these trials that are being run are not just monotherapy trials, they're combination trials, potentially with, a PD-1 backbone or a chemotherapy backbone. And we really don't actually have enough patients to treat all of or to fill all of these trials. And I would argue that the majority of the trials are not necessarily looking at rational combinations. They might just be looking at 2 agents that the same drug company may own. And oftentimes, instead of identifying the optimal combination, we're really just throwing spaghetti at the wall and seeing what sticks. So I think that we really need to take a step back and better understand what's happening in the tumor microenvironment and within the immune system in our cancer patients before we make steps forward and really jump to large, 100-person or 1,000-person trials, which many of the ones that are opening right now, they're actually closing due to poor accrual. So our first step is that I think that we need to take a bit of a step back. One of the first things that we have to do that is work that's been underway for nearly a decade now in Miriam's group and Nina's group and other folks in the Immunology Institute and in the Cancer Institute is to really grasp the baseline tumor immune microenvironment. What do untreated cancer lesions look like? And specifically looking at the complexity within the lymphoid and myeloid lineages. This is something that we are just now starting to appreciate with new technologies that are coming out that really allow us to identify subclasses of macrophages, of T cells, et cetera, and find different ways in which we might be able to target those cells, either by activating them or depleting them from the tumor microenvironment. And then finally, we really don't have any idea what these therapies that we're using in patients are doing in vivo. We don't really even understand what PD-1 blockade is doing in humans in vivo. And so if we can better understand that, if we can better understand what classical therapies like chemotherapy and targeted therapies are doing to the immune infiltrate, specifically using all the new technologies we have, then I think that we're going to be in a much better place to make some big steps forward. So first, taking a look at some of the work that's been going on and which is ongoing to understand the baseline tumor immune microenvironment. Many of you are well aware of this beautiful Cell paper that came out of Miriam's lab that Yuniv was the first author on, that did a very nice single cell characterization using primarily mass cytometry of early stage lung cancer lesions. So these are small tumors. Most of them were stage 1 tumors. What they did was they took the tumor and they also took the quote unquote neighboring normal lung tissue. Obviously this lung is not completely normal because it's sitting right next to a tumor. They basically made a single cell suspension of these 2 tissues. They took some of the paired blood at the same time. They barcoded these tissues and they ran them on using myeloid and lymphoid panels on the mass cytometer. And some of the things that we see enriched in the tumor compared to the neighboring normal lung are things that you would expect, such as an increase in the T regulatory cells, an increase in the exhausted PD-1 positive CD4 and CD8 T cells, potentially those are effector T cells as well. But we also see kind of an interesting mix of changes that there's a lot of heterogeneity between patients also, particularly in the myeloid populations as well as the NK cells. And one of the things that you notice just off the bat is if you just look at macrophages, you look at macrophages as an entire population, you don't really subset them. There are lots of macrophages in the lung. We already knew that. There's lots of alveolar macrophages and other resident macrophages in the lung. So many more than you would expect in the peripheral blood. But in the tumor itself, there's not a significant increase in macrophages. It's almost a comparable number of macrophages infiltrating the tumor compared to the neighboring tissue. However, we know that when we take out a lung tumor, there are lots of neutrophils, there are lots of macrophages, and we think that their functional status is significantly different than what you would see in normal tissue. And that's exactly what you need, and a very large group of collaborators showed in this paper. If you look at the transcriptomic signature of the macrophages from the non-involved lung, so these are the quote-unquote normal macrophages, most of them are alveolar macrophages, and you compare that to the transcriptomic signature of the macrophages that are enriched within the tumor, you see that there is a significant difference between these two populations. And there, at the transcriptomic level, we can see that functionally the macrophages enriched in the tumor have a very immunomodulatory, immunosuppressive, I guess you could say, phenotype that really promotes T regulatory cell differentiation, recruitment, and really stymies the ability to develop a solid anti-tumor T cell response. And that thought process is sort of supported by this data, which shows that there's a direct correlation between the number of these macrophages that have the suppressive monocyte-derived macrophage, tumor macrophage phenotype. There's a direct correlation between the number of those and the number of T regulatory cells, as well as the number of dysfunctional or exhausted T cells and NK cells within the tumor. So there definitely seems to be a correlation. Obviously, we can't say anything about the causative nature of this. But when Yonit took the transcriptomic signature of these tumor-enriched macrophages and compared it to the non-involved lung macrophages, she saw that a transcriptomic signature in this TCGA data set that showed a very prominent tumor-associated macrophage signature based on her data from the left side of this slide, correlated with a much worse overall survival. And we know from many data sets that go back more than a decade that a significant infiltration of macrophages into tumors across histologies other than maybe colorectal cancer and prostate cancer, macrophages really do typically portend a poor survival. But here we're really looking specifically at macrophages that are having this immunosuppressive transcriptomic phenotype or transcript signature compared to the signature seen in the normal macrophages, the tissue resident macrophages within the lung. So along with looking using mass cytometry and some of that bulk sequencing, the lab has been doing a lot of work looking at single cell transcriptomic data from these early stage lung cancers. And this is work that has been done by literally dozens of folks in the lab and in the HIMC are involved in some of this analysis. And the data analysis has really been spearheaded by Andrew and Effie. And not only are we looking at single cell RNA sequencing using the 10X platform, they've also been looking at site-seq analysis. And some of you are aware of site-seq, but just to go over it quickly, along with getting the cDNA libraries that correlate with the whole transcriptome within cells that are isolated from a tumor or any tissue for that matter, cells can first be stained with antibodies against protein antigens that can be cell surface or intracellular. And these antibodies, as opposed to flow cytometry or mass cytometry, where antibodies are conjugated to fluorophores or heavy metals, these antibodies are correlated or conjugated to long oligos, so that when you basically are creating this single cell encapsulation and you develop these cell-specific cDNA libraries, not only do you get a cDNA library that represents the whole RNA transcript within the cell, you also get a cDNA library that correlates with all of the oligos attached to the antibodies that bound to that cell. So you're getting basically a combination of the best of both worlds of mass cytometry and single cell seq all at once. So a really preposterous amount of data per cell. Andrew and everyone in the lab has been using this technology in a similar fashion to what I just showed you from Yonit's paper. So once again, I'm taking early stage lung tumors. These are untreated tumors that are being resected in the OR. They're brought over here, and then normal lung tissue that's neighboring, as well as the tumor, are dissociated into a single cell suspension. Typically there's a CD45 enrichment from most of our protocols. So it's just isolating the white blood cell infiltrate within the tumor. And then these cells are stained with a cocktail of antibodies that are tagged to oligos. And then using the 10x platform, we perform single cell seq. And the benefit here is not only are we looking both at the tumor and also the matched lung, similar to what we were doing in Yonit's data set, we get not only the single cell RNA expression, you also get single cell proteomic data. And this is a much larger data set than you might get from a single CyTOF panel. And additionally, you're also getting 5' TCR sequencing data. So this really allows you to look at clonal expansion of T cell populations. Not only can we see the expansion, but we can then actually look at the phenotype of those cells and really understand their activation status or lack thereof. So this is just one example of the benefit. So the real reason why CytSeq is really exciting is that when we're doing 10x sequencing, oftentimes there are certain protein markers that we use to identify lymphoid or myeloid lineages, such as CD4 and CD8 for T cells, or CD16 and CD56 that identify different subsets of NK cells. And oftentimes when you look at the transcripts for these proteins, the RNA is at a very low level, and sometimes it's hard to differentiate a CD4 from a CD8 T cell, particularly since there is CD4 RNA in CD8 cells, or at least early CD8 cells as well. So the transcripts alone don't really allow you to hone in and identify and be very sure of certain lymphoid and myeloid populations per se. But when you have the transcript data and the protein data, you can be much more confident of the populations you're looking at. As an example, LIL-RA4 is a transcript that is very commonly seen in plasmacytoid dendritic cells, which is a relatively rare DC subset that's important for antiviral and also anti-tumor activity. If you look at this population, this correlates with a very strong expression of CD123, which anybody who studies PDCs knows is the sort of classic cell surface protein marker that we use in flow cytometry to look at PDCs. But anyone who uses this also knows that CD123 is expressed on a variety of other mononuclear phagocytes as well. So by itself, CD123 doesn't give you a definitive idea of if you're looking at a PDC population, but you can be much more confident you're looking at PDCs when you can combine the transcriptomic data and the proteomic data at the same time. So very large data set that's very exciting that hopefully will allow us to do a deeper dive into these sort of subsets and fragments of the T cell and myeloid populations that we're most interested in looking at. So using a combination of data of CytSeq and also single cell RNA sequencing on these early stage tumors, Andrew and the whole team have shown some things that you would expect based on Yonit's paper and many other papers, that within the tumor you see a significant increase in the T regulatory cells compared to the neighboring normal lung. So this is something that is characteristic of just about every type of cancer. But also interestingly, Yonit had showed that there were comparable number of macrophages in the lung and the tumor. But what we see is that in the tumor, there's a significant depletion of the tissue resident macrophages, which in the lung are the alveolar macrophages, compared to the neighboring normal lung. But there's a significant increase in these monocyte-derived macrophages. So this really correlates nicely with her bulk data that showed that there were these two distinct phenotypes of macrophages in the tumor and macrophages in the neighboring tissue. So this data is just the tip of the iceberg of creating a really exhaustive baseline tumor atlas to understand the different immune cells within the tumor, because not only is there a lot of heterogeneity within a tumor, there's also a lot of heterogeneity between patients based on smoking status, mutational status, etc. But we're slowly learning more and more. Andrew is putting together a really beautiful manuscript of the data he's collected on a very large cohort of patients. So some of this data is really allowing us to better understand the complexity within the lymphoid and myeloid lineages. And I think this is really key for us to understand how to therapeutically target these different lineages in a intelligent way, as opposed to sort of a brute force way, which I think is what we oftentimes are doing nowadays. So as I showed you earlier, Yunit showed that this, if you have a high, you could call it a TAM signature, but it's basically a high transcriptomic signature of macrophages that are associated with the tumor versus the types of macrophages that are associated with the normal lung. This correlates with worse survival. And again, you know, we know that macrophages within the tumor in general correlate with worse survival across tumor types. And what we're starting to see is not only do we have our tissue resident macrophages, you know, in lung, it's the alveolar macrophages, and liver, it's the Kupffer cells, but we have a variety of different monocyte-derived macrophages within the tumor that in the past might have been lumped together with the alveolar macrophages. We also have monocytes that are extravasating from the blood into the tissue and slowly going through a progressive development into becoming these novel macrophages, inflammatory macrophages, typically within the tissue. And then there's additional subsets of macrophages. Interstitial macrophages is just one subset that we know most likely plays some sort of role in maintaining homeostasis within these tumors and sort of quieting some bad types of inflammation that might lead to fibrosis and, you know, some of the toxicities such as that we're seeing in patients with COVID, for instance. So many of you had heard about TAMs or MDSCs. So TAMs is tumor-associated macrophages, MDSC is myeloid-derived suppressor cell. These are kind of umbrella, very non-specific blanket terms for myeloid subsets that refer to granulocytic subsets, monocytic subsets. It's a bit of a blanket term. I don't think it's particularly useful because I think that we need to understand the multiple different subsets and the importance of those different subsets to better target them. But you know, there's lots of trials that say, all right, we're going to deplete the TAMs and the MDSCs from tissue. And one example is lots of companies have developed antibodies against CSF1R. This was initially studied, in many different types of cancer. The initial success was seen in a very rare condition of tenosynovial giant cell tumor, in which due to the production of MCSF by the malignant cells, or the, I don't know if they're really considered malignant cells, you had this huge accumulation of monocytes that basically create a tumor, but it's basically just a tumor made entirely of myeloid cells. This antibody that has been tested, there's dozens of them that are in development and in clinical trials, some of them in very advanced clinical trials, that really is geared towards decreasing the production and recruitment of myeloid cells into the tumor. However, CSF1R is not specific to, you know, quote unquote, the bad guys. CSF1R is expressed on most myeloid cells, and you can see here, this is just a graph from Yonit's paper that showed that while there is a high level of CSF1R on macrophages and the CD14 positive monocytes, these are the, I guess you could call them the bad guy monocytes, the inflammatory monocytes that we think are differentiating into these monomacs that are really propagating this tumor microenvironment that is very pro-tumorigenic. We also see that the CSF1R is expressed on CD141 dendritic cells. And this is a relatively rare subset of dendritic cell. Many of you know it as DC1. And DC1 is characterized by the BATA3 transcription factor. So these are CD103 positive dendritic cells in mice and CD141 dendritic cells in humans. And there's a lot of data to show that these cells we don't want to deplete because they're extremely important for the responsiveness to immunotherapy. There's many examples of this in the literature, some of it from here at Sinai. This is a paper by Aline Salman that was in Immunity in 2016, I believe. And in this trial, this is just one example where they were growing the B16 melanoma model. And in this is a somewhat responsive model to PD-1 blockade, to checkpoint blockade. So if you introduce an anti-PD-L1 into these mice, you see a significant decrease in the progression of the tumor. Obviously, the tumor is still growing here. But if you knock out BATA3 and you get rid of these very key but very rare DC1 subset, you lose all responsiveness to PD-1 blockade, all benefit from PD-1 blockade. And similar data has been reported by multiple groups. Even the same year in 2016, there was at least 3 high-impact papers that showed basically identical data, the importance of this DC1 subset in priming a T-cell response. These are the most optimal primers of CD8 T-cell response because of their ability to cross-present antigen. And without these cells, you really will not benefit from immune therapy. So it's possible that by depleting CSF1R positive cells and disrupting that normal pathway, you're going to lose all benefit from the good guys in the myeloid population. And I put this up here in part just to be somewhat controversial, but this is a paper that we had a very robust journal club in early January discussing. It was an interesting paper in which they knocked out PD-1 on myeloid cells, where we typically think of PD-L1 being expressed on myeloid cells, but they knocked out PD-1 on myeloid cells, and they saw basically a complete loss of tumor growth. And so it seemed like by blocking PD-1 on myeloid cells, you could potentially have the best benefit, while if they knocked out PD-1 on T cells, they only saw a modest decrease in the growth of tumors. I'm not sure I would hang my hat on this. I think it's an interesting hypothesis generating paper, but it does go sort of support the idea that we shouldn't necessarily just get rid of all myeloid cells, because if we deplete the entire tumor and body of myeloid cells, I think that we basically are just throwing the baby out with the bathwater, and we're not, differentiating between the two. And it's really, this sort of underscores the importance to better understand the different subsets, different myeloid subsets, the different macrophage subsets, so that we can understand who the good guys are and who the bad guys are, and how we should modulate them potentially clinically. And so just to harp on this a wee bit more, we know that not all macrophages are created equal. And I already showed you that alveolar macrophages in the tumor are significantly decreased compared to the normal neighboring lung, while there's an increase in these monocyte-derived macrophages that we think potentially are derived from these circulating and then extravasating inflammatory CD14 positive monocytes. If you take a look at some of the site-seq data that is being created of these early stage lung cancers, and so this is all human data. Once again, we're seeing, this is the transcriptomic data on top and the proteomic data on the bottom. Once again, we're seeing this alveolar macrophage population, but also we're seeing this very large monocyte derived macrophage population. You can see that there is further subclassification within this monomac group, which we think is potentially derived from extravasating inflammatory CD14 positive monocytes. And CD16 monocytes here are kind of the classical monocytes that wouldn't necessarily propagate this tumor microenvironment, which is hijacking your normal ability to respond to the tumor. And if you look at these different populations and you compare normal lung, which is below the red line, to the lung tumor, which is above the red line, you see that there's a significant enrichment of these monomac populations within the tumor, almost exclusively representative in the tumor compared to the normal tissue, which again supports that there's something about the environment within the lung that is supporting the development of these monomac populations as they recruit these inflammatory monocytes out of the blood. And we think there is most likely some sort of linear progression of development of monocytes leaving the blood and developing into these macrophage populations, which help further support tumor growth and also tumor invasion and metastasis. So that was primarily human data I was showing you. This is some data that Andrew and Maria have been putting together that it showed that there are, in humans, we see basically four overarching groups of macrophages. I don't know how to make my phone not ring. Four overarching groups of macrophages. There's on the group one represents, the tumor resident alveolar macrophages. Group two is a bit of a motley crew. It's a mixture of interstitial macrophages and these monocyte-derived macrophages. Group three, this is really where we're seeing these inflammatory macrophages. So the CD14 monocytes sort of converting into these monomac populations that I was just showing you that we think are probably, when we're talking about TAMs, these are probably the bad guys that we should be targeting with our therapeutic interventions. And finally, group four here, which is relatively small in the lungs that we're looking at, are the classical CD16 positive monocytes, which should be a relatively small population. We see a similar grouping in a lung cancer model in mice. So this is a KP model that Maria has been working with. It's KRAS mutant P53 deficient lung cancer model that is administered, it's given as a tail vein injection. So basically it's a model of metastatic disease to the lung. And what we see, or what Maria saw when she took out the tumors in the lungs from these mice, is that there are four distinct populations. Once again, they're the tissue resident alveolar macrophages. There's this group two, which, as you can see, is a bit of a mixed population, which encompasses the interstitial macrophages and some other monomacs. And then there's this group three population, which has a transcriptomic signature, which is very immunosuppressive is not the right word, since these are inflammatory monocytes and monocyte-derived macrophages, but it's very permissive for continued tumor growth. And these cells are characterized, these sort of inflammatory monocytes, which are CD14 positive in humans. They are CD16 high, Ly6C high in mice. And these have a very high expression of CCR2, which is a chemokine receptor that binds a variety of chemokines and cytokines that are secreted by cancers and a variety of other inflammatory situations. And we see similar high expression of CCR2 on the CD14 positive monocytes in humans. So it does seem that we have the bad actors in the humans that correlate with the bad actors in the mice. And interestingly, in these mice, the naive status here is before inoculation, and then as the tumors are growing, it does seem like there is a progressive recruitment of these Ly6C high monocytes into the lung and into the tumor. And that's not surprising because of additional data. Maria has a nice manuscript that is in preparation that shows that while alveolar macrophages are most likely important for the initial seeding of a tumor and the initial growth of a tumor in the lung, it's really in later stages, once you have a macroscopic tumor, that the alveolar macrophages are, you could say, crowded out, and these inflammatory macrophages take over the role of helping propagate EMT, metastasis growth, etc. So we know that in cancer cells and in cancer patients in general, if you do bone marrow biopsies, we see what we call aberrant myelopoiesis. And that's for a variety of factors. So tumor cells secrete, cancer is an inflammatory disease. Tumor cells secrete lots of cytokines and growth factors. Some tumor cells actually secrete high levels of GCSF or GM-CSF. And this leads to aberrant growth of myeloid populations within the bone marrow, and then extravasation of these immature or sort of early granulocytes and mononuclear cells out of the blood and into the tumor cells. And one of the ways in which these cells traffic out of the bone marrow into the blood and then out of the blood into the tumor is through a variety of different chemokine gradients. But it's believed that CCR2 and also potentially CCR5 are extremely important at the recruitment of these cells. And these cells have a relatively short half-life. So this is a constant process where tumors are recruiting more and more neutrophils. They're recruiting more and more myeloid progenitors that have a very immunosuppressive phenotype. So this is a process that is going on continuously. And if we look at the blood of patients who have metastatic cancer, tumor burden oftentimes will correlate directly with the amount of these chemokines, as well as cytokines such as IL-8 that are responsible for recruitment of neutrophils, and particularly these immature granulocytes into the tumor. So it's basically an endless cycle where the cancer is recreating this myeloid population within the tumor and propagating it and increasing it to allow for growth and metastasis. So Maria looked at a CCR2 knockout, and in this mouse, you basically lose, as you would expect, the Ly6C high monocyte and monomac population, but you do not lose the Ly6C low population. So this is not basically knocking out the entire monocytic lineage. And in these mice, we see a significant decrease in the not only the number of tumors, but also just the tumor burden within the lung. And this really correlates with the hypothesis of her other data, which will hopefully come out soon, that shows that these cells are really important, not only for the establishment of tumors, but primarily for the growth of tumors and for EMT and metastasis of these tumors. So we're starting, that was just a little taste of our deep dive into the lymphoid and myeloid compartment to better understand T cell subsets, myeloid subsets, so that we can, if we have a better understanding, I think that we can make a much more intelligent argument about how we should modulate the tumor microenvironment to make immunotherapy or chemotherapy or any therapies that we're looking at work much more effectively. So the final question, which is my favorite question, is what do these therapies do in vivo? So we have all these therapies. I just showed you that graphic that showed that there's 4,000 different IO therapies in development, but we don't really understand what these do in vivo in humans. It is very difficult to study this. We don't even understand what PD-1 blockade does in humans. We can do, pre-treatment and on-treatment biopsies of metastatic lesions, but we all know about the heterogeneity of tumors and also the poor quality of the biopsies that we get. So it's very difficult to actually study in vivo. But the one way in which we're able to do this is use what we call window of opportunity trials or neoadjuvant trials, which I think are one of the optimal settings to study any therapeutic intervention, particularly these immunotherapies, where we really have to see what are the changes at the microscopic level and at the transcriptomic level that are induced by these therapies that are being pumped out by pharma by the dozen. So for patients, I think that the neoadjuvant setting is extremely beneficial. Neoadjuvant, by the way, just means treatment before surgery. So basically, when we are talking about a neoadjuvant trial, we have a patient who comes in, they're planned for an operation to resect their tumor. What we can do is we can get a bunch of biopsies beforehand. We can give them a short period of treatment. Neoadjuvant just means before surgery, and then we cut out the tumor and we can look at the tissue pre-post to really see what's happened. So neoadjuvant therapy is standard of care in certain types of tumors. In lung cancer, it can be considered standard of care, but it's more commonly not deferred, and chemo is given afterwards. But I think that in the neoadjuvant setting, especially to investigate immunotherapies, I think that these patients will benefit because they have better immune fitness than post-chemo, or the patients who are getting immune therapy right now that typically have metastatic disease, who oftentimes will have a very inflamed baseline phenotype because of all the reasons I just mentioned. These patients also have smaller tumors. The tumors, we believe, have less heterogeneity, which is typically the case, particularly if they haven't spread to lymph nodes or distant organs. And then we also were seeing less loss of heterozygosity, which would also make them more susceptible to immune detection and elimination. So I would argue that compared to the metastatic setting, where we are for the first time actually potentially curing some lung cancer patients, I think there's even a higher chance for cure with immune therapy in the neoadjuvant setting than in the metastatic setting. For the physician scientist, the neoadjuvant setting is extremely exciting. It's really going to help us define mechanism of action in vivo of these therapies. It'll help us define biomarkers of responders and non-responders so that we're not giving patients futile therapy. All these therapies have significant physical toxicities as well as financial toxicities. And so we want to choose the most personalized therapy possible. We can run significantly smaller trials. So we don't need a 100-person trial to look for a clinical signal. We can look at a much smaller population, and by deep analysis of the tumor tissue before and after, we can see exactly what's happening and which patients are responding and which are not. And the goal here really is that we put fewer patients on trials in which the therapy is futile, because that's a waste of our time, and it's most importantly a waste of our patients' time if they're not going to actually get any benefit from it. And most importantly, the goal here is to use all the analysis and this deep dive immunologically that we're doing to propose rational combinatorial approaches. So instead of just giving everyone PD-1 blockade and CTLA-4 blockade, really identifying maybe in a tumor type specific way, maybe in a patient specific way, what is the optimal combination for that patient's tumor that will allow an appropriate immune activation and elimination of the tumor. And neoadjuvant trials are very common now. The first one in lung cancer was reported almost or over 2 years ago in 2018 now. This was in lung cancer. This was from some of our colleagues down at Hopkins and Memorial. And they gave 20 patients 4 weeks of nivolumab. So just 2 infusions given every 2 weeks. And then they took them to the operating room. And while a few patients, there was 2 patients who actually had a significant radiologic response. There was a 10% radiologic response. You can see that the majority of patients actually had a pathologic regression of their tumor. And 45% of the patients actually met one of the secondary endpoints, which is major pathologic response, which means 90% or more necrosis of the tumor following this very short, very well tolerated immunotherapy intervention. It's much better tolerated than chemotherapy for sure. And interestingly, they saw this across different tumor types. They saw it in non-smokers as well as smokers. Smokers were obviously the majority of patients, and they saw it in different histologies as well. So very promising data from this initial report. There's a larger study that is being run out of Spain. This is called the NADIM trial. And this is looking at patients who have locally advanced cancer, so stage 3A cancer, which means either a very large tumor or metastatic spread to the mediastinal lymph nodes. So these patients, they're technically surgical candidates, but many times we would give them neoadjuvant therapy. Here, what is happening is these patients are getting neoadjuvant chemotherapy, so platinum, taxane doublet in combination with nivolumab. So if they were to get neoadjuvant chemotherapy alone, which would be a standard therapy, we would probably expect around a 20% major pathologic response rate. However, what they're seeing so far, and this data was most recently updated at World Lung last year, is that we are seeing an 83% major pathologic response. So by adding on this nivolumab to the chemo backbone, we're actually seeing what appears to be a quadrupling of the major pathologic response. And this is known to correlate in chemotherapy-treated patients in lung cancer with an overall survival benefit. And so this is extremely promising data that hopefully we'll get an even larger and more robust update come ASCO in June. And this is one of the, chemotherapy and immunotherapy together is now, as I mentioned on one of the first slides, it's our standard first-line therapy for metastatic cancer. And as an immunologist, I was baffled by this trial design 5 years ago when they first started talking about it, because not only are you're basically giving in parallel an immune stimulant or a exhaustion releaser, or whatever you want to call it. You're giving pembrolizumab, which is going to rev up your T cells. And then you're also giving chemotherapy, which itself might be somewhat lymphotoxic to those T cells that you're revving up. And oftentimes we are giving high doses of steroids, including, I mean, most of the time it's dexamethasone, a very high dose that theoretically should kill off all circulating or cycling T cells. So you think that you would be basically negating any benefit you're getting from either therapy by adding the chemotherapy to the immune therapy. But, you know, we seem to see synergy, although it's arguable, it might just be additive benefit in the metastatic setting, but we're also seeing it here in the neoadjuvant setting. So we have a trial that I opened last summer that's been accruing that is looking at this very question. We're trying to understand what is the synergy between chemotherapy and immunotherapy. So what we're doing is we're giving cemiplimab. This is a PD-1 antibody. It's basically the same as pembrolizumab. Some data last week show that it has nearly identical efficacy in the metastatic setting to pembro. So we're giving either that alone, that with chemo, or 2 cycles of chemo to patients before surgery. We're getting a bunch of biopsies and blood and some stool before surgery or before treatment. And then obviously we're cutting the tumor out. We're getting a bunch more blood and stool at the time of surgery. We're also doing imaging and we're looking at radiomic markers of response as well. And this is a trial that's not only accruing into lung cancer, we also have an HCC cohort. This is more than half accrued at this point, and then a head and neck cohort as well. And so this window of opportunity is very exciting. I think that we could answer a lot of questions. One other question is, can we use this window of opportunity to target this monocyte-derived macrophage population that I just showed you all the data on from the work that's been done with Miriam's group? So we know that through a CCR2 mediated mechanism, this aberrant myelopoiesis is leading to these immature granulocyte and monocyte populations that are being recruited into tumor cells and just, you know, further propagating the development of these tumors. If we could somehow cut off this recruitment and the production of these cells, we may eliminate this one mechanism in which tumors are basically hijacking our immune system. So one way we can do that is we can use a CCR2/5 inhibitor, which blocks this chemokine recruitment pathway. And we also can use an anti-IL-8. IL-8 is a cytokine that's very important, particularly for the recruitment of these immature granulocytes into the tumor. And so we're doing that in the neoadjuvant setting as well. This is in potentially smaller lung cancer tumors that don't necessarily need chemotherapy, but still have a significant chance of recurrence. We're combining nivolumab, which is a PD-1 antibody, with either an oral CCR2/5 inhibitor or an IL-8 antibody. And these are, you know, combinations and agents that have already been looked at in the metastatic setting, and we don't have any significant concerns about toxicity that might delay surgery, which is obviously an important concern. And here we're doing, you know, nearly identical biospecimen collection and analysis. Really doing a deep dive to try to understand what these agents are doing, and if this is a very good combination, or if we could even improve further upon this combination. And this is actually one of the first trials that's going to be funded by the Foundation for National Institutes of Health, which is sort of a public-private partnership that we can work with through the CMAC we have in NCI, which is headed up by Sasha. So quickly, I'll jump from cancer to COVID, since COVID is very hot right now. And CCR2, we know in cancer, promotes this monocyte-derived macrophage accumulation within tumors and probably propagates the tumor growth and the tumor metastatic potential. Potentially, CCR2-mediated recruitment of monocyte-derived macrophages and inflammatory macrophages is very important for the destructive part of the COVID disease. So some of you may know, but what we're seeing in the clinic, and what was also seen with SARS-1, the SARS that we had back in 2003, is that this disease is a bit of a biphasic disease. Initially, patients have more not insignificant isn't the right word, but they have less severe symptoms and sometimes are completely asymptomatic. And one of the thoughts is that this may be stymied by a low interferon response by infected pneumocytes due to a variety of different mechanisms in which SARS-CoV-1 and 2 can inactivate the normal interferon production pathway. But what happens is that as your virus actually potentially is even being cleared, there's this robust inflammatory response, particularly in the lungs, that's leading to recruitment of a variety of myeloid cells, particularly inflammatory monocytes and monocyte-derived macrophages, that are then leading to local destruction in the lung and the pneumonitis that in a subset of patients is landing people in the ICU and potentially even intubated. So this is really this second phase of this biphasic disease, which happens in a minority of patients, and we don't know exactly why that is. That's really the deadly part of COVID. So the way that coronavirus infects is that it can infect the alveolar type 1 or type 1 pneumocyte and type 2 pneumocytes within the airways. These both express high levels of the ACE2 receptor, which is the mechanism of entry of SARS into cells where they obviously propagate. Normally, when these cells are infected, let's say by influenza, there's a strong induction of type 1 and type 3 interferons that basically kick off the inflammatory response, make us feel very ill, but also lead to the more rapid resolution of infection. However, Ben Tenover's group a couple months ago actually did some analysis where they were looking at the transcriptomic signatures associated with the infection of type 2 pneumocytes with either SARS-CoV-2, which is the virus causing COVID-19, influenza or respiratory syncytial virus. And they saw that there was an incomplete overlap, and most importantly, the SARS-CoV-2, you really didn't see the downstream induction of the interferon-stimulated genes that you would expect to see that would really induce recruitment of the appropriate immune cells, but also the induction of T-cell and humoral immunity against these viruses. So it seems like the interferon pathway may be inactivated. This is supported by some data that was published in 2016 looking at SARS-1, which showed that in many patients, there's this delayed interferon response. This is just a schematic from this Cell paper that you can look up. This delayed interferon response is really is associated with a significant swell in the release of CCR2 ligands. There's this really prominent recruitment of CD14 positive inflammatory monocytes. These monocytes and monomacs accumulate within the lung. They secrete lots of cytokines. They basically, including IL-6 and TNF and the things that we're seeing on the Olink analyses we're doing on these sick patients. This is the cytokine storm that is resulting in patients getting intubated and also lots of other end organ damage. And the significant macrophage recruitment was seen back in 2003 in these patients who had severe COVID, or sorry, SARS-1, I guess you'd call it. And we're seeing the same sort of pathologic findings in autopsy specimens from patients who succumbed to severe COVID. This time, this is data from Wuhan. And this study looked at this is again from Cell Host Microbes, this is looking at SARS-1, whether or not depleting the myeloid component of the immune system within these infected animals, this is all preclinical data obviously, would abrogate the severity of the disease, and that's exactly what they see. They see increased survival and increased resolution of symptoms if you do not have this robust myeloid infiltration into the lungs. So it does seem that these myeloid cells are playing a particularly bad role. How do we block the recruitment of these inflammatory monocytes? Well, in the exact same way that we are doing it in lung cancer, possibly, by blocking CCR2-mediated recruitment, because inflamed tissue is dumping a lot of these ligands into the blood. And if you look at well, I'll show you the plasma in a second. If you look at there's two studies looking at bronchoalveolar lavage from patients in Wuhan And here's 2 patients on the right, 3 BALs from control patients, and you see this is bulk analysis, bulk transcriptomic analysis. You see that there's a very distinct profile in the inflamed lungs versus non, which is not surprising. But if you take a closer look, you see that there's a whole slew of chemokine and cytokines that are upregulated in the cells taken from these BAL. And you can see a lot of the CCR2 and 5 ligands are significantly upregulated in these patients. There's another BAL paper that the manuscript was just put online. Here, this is once again from Wuhan. They took 3 severe patients, 3 mild patients, and 3 healthy controls, and they took a look at the cellularity within the BAL. In red, you see the normal alveolar macrophages. That's obviously the majority of macrophages in the healthy controls. It's still potentially a majority in the patients with mild disease, but in patients with severe disease, you see a near complete lack of the normal alveolar or tissue resident macrophages, while you see lots of these FCN1 high macrophages that correlate with the CCR2 positive, in mice, the Ly6C high inflammatory monocyte derived macrophages. And so very high levels transcriptomically when they look at these, they did single cell analysis of these, of CCL2, CCL3, CCL5, many different chemokines, including IL-8, interestingly. And finally, this is just some plasma also taken from Wuhan of either healthy controls, patients who are in the ICU, or patients that did not require ICU care. And you see that in both the patient populations, particularly those in the ICU, you see significant increases in the plasma concentration of CCR2, CCR3, CCR4, and CCR5. So all of these are ligand, sorry, CCL2, 3, 4, and 5. So all of these are ligands for CCR2 and 5, also supporting the importance of this CCR2-5 axis in the development of the severe pulmonary inflammation. So we've developed this trial. This is actually with a different CCR2-5 inhibitor from Allergan, with which Sinai has a lot of experience. Scott Friedman actually led one of the largest phase 2 trials of this agent. It's very well tolerated. Here are patients who are not yet critically ill, but are admitted and requiring supplemental oxygen will be randomized to receive either the CCR2-5 inhibitor, which I cannot pronounce, or a placebo, while they're also receiving standard therapy, which most likely would be remdesivir, potentially with some plasma. So the only differential factor will be these 2. So this is just a small taste of the hundreds of people that I should be thanking who make all of this translational work possible. As Hillary says, it does take a village, particularly for work like this. And with that, if anybody has any questions, I'd be happy to discuss.
Great, thank you, Tom. So we have one question from the audience, from Quan Lin. He says, great talk, first of all. Does the 83% response reported by NADIM seems robust? Does it seem robust? Sorry, I gave it to the wrong accent there.
Yeah, I mean, well, it's basically 4 times the major pathologic response that we would expect with chemotherapy alone. So by adding immunotherapy, you're quadrupling the potential benefit. The endpoint is a pathologic endpoint. It's not a long-term survival endpoint. And so that's obviously the most important endpoint, is overall survival. There is data correlating MPR, so that 90% or more pathologic response with overall survival, but that's in the chemotherapy data set from the last few decades. We don't really know, we can't extrapolate chemo data to immunotherapy data per se. And so until we have overall survival data, I don't think that we can be 100% sure, but I would, I would suspect that people would do even better, because having a pathologic response to chemo just means your poisonous treatment is killing a bunch of cells, which is what you would expect. When you're seeing tumor necrosis with the addition of immunotherapy, theoretically you're potentiating a memory response, a vaccinal response of sorts, so that you might have a whole workforce of T cells to look for micrometastatic disease and further decrease your likelihood of recurrence and death.
Okay, and kind of a part B of that is, since you do think it seems robust, how could response in low TMB or neoantigen cold tumors be explained?
That's a very good question. I think that TMB and neoantigen is a ambiguous space that we don't understand entirely. There was a nice trial that was reported at AACR that was looking at TILs, basically reinfusion of revved up tumor infiltrating lymphocytes into patients. And in one patient who had an EGFR mutation, they actually saw a significant response. And EGFR mutant patients have the lowest number of neoantigens and the lowest TMB. Sometimes they maybe just have one mutation, which is their EGFR mutation, but they actually were able to elicit a entirely immune-based response there from a vaccinal effect type of benefit as well. So I think that it's possible that these driver mutant patients like EGFR or ALK-ROS mutant patients would benefit from this combined chemoimmunotherapy. We don't really have data in the metastatic setting convincingly saying yes or no. And so I think that we still need to learn a lot more about the immunogenic drivers of response to immunotherapy or combination in patients who have mutant disease. And Andrew's paper actually, his data set has a decent number of EGFR mutant patients. So I think we're going to learn a lot more from that data set as well.
Okay, great. We have two questions, one from Fiona and another from Mihaela Scove, both focused on CCR2. So I'm going to mention both of them and feel free to answer. First off, from Fiona, great talk. Is there evidence or clear association of reduced CCR2 ligand signature in patients who respond to checkpoint in any of your human tumor data? And then coming from Mihaela, in preclinical cancer models, blocking CCR2 led to unexpectedly to loose outcome due to compensatory mechanisms. Can you comment on potential pitfalls?
Well, so as far as in patients responding to immune therapy, I mean, in patients responding to immune therapy, you have typically lower tumor burden. So you might have a lower number of CCR2 ligands just because many of those ligands are being produced either by the tumor themselves or by the infiltrating myeloid and stromal cells that are sort of propagating that myeloid-rich population. I don't know of any studies that have specifically, looked at plasma over time and seen if they do see a decrease, but it's something I would expect that we would see. I didn't understand the second question. I didn't understand.
I can repeat it now. I think there's a clarification now. In preclinical cancer models, blocking CCR2 led to unexpectedly worse outcome due to compensatory mechanisms. Can you comment on the potential pitfalls of CCR2, CCL2 antagonist treatments?
I'm not aware of those preclinical studies where you actually saw a lack of benefit. I think that there's a lot of preclinical and clinical studies that show that there's a potential benefit by depleting these subsets. You could argue that CCR2 is important for the recruitment of certain myeloid cells. I mean, the production of them and recruitment out of the bone marrow as well. And so when I make that joke about throwing the baby out with the bathwater, I don't think that CCR2 is a perfectly targeted therapy. I think it is better targeting than CSF1R, for instance, because CCR2 is at much higher levels on these inflammatory monocytes and monocyte-derived macrophages that we know have a correlation with a bad outcome. But yeah, it'd be great if you could send me that paper just so I could compare and contrast.
That question comes from Mihaela Scove, so maybe she could circle back to you with the paper.
Yeah, great.
Due to time, we have one more question we'll take from Sindora. It's kind of a long one, so hold on. Question, referring to a statement about neoadjuvant immunotherapy in LUAD, how was loss of heterozygosity measured in patients? What does it mean when you mention that they have less loss of heterozygosity?
So it hasn't been measured in patients. That's a theory, is that I think that with smaller tumors, there is data showing that as cancer progresses and metastasizes and you get more heterogeneity, you do have loss of heterozygosity that correlates with tumor burden. And so the theory would be that if we are treating patients earlier on, if you have smaller tumors, you have less heterogeneity. So you won't have certain neoantigens present in half the tumor versus the other. Oftentimes we'll see different neoantigens pop up in one metastasis versus another, which is why it's not uncommon with immunotherapy treated patients with metastatic disease to see mixed responses where 9 out of 10 tumors will shrink and 1 tumor will continue to grow. It's possible that when we see that phenomenon, it can be associated with a loss of heterozygosity. So you lose you basically lose the ability to present a certain neoantigen on that HLA. But I don't think in the neoadjuvant setting we've demonstrated that yet. So I think that's one of the things that we'll be interested in looking at.